Hello and welcome to another episode of Cracking Addiction. My name is Thileepan Naren and I'm joined as always by Dr. Ferghal Armstrong. In the episode of Cracking Addiction today, we're going to be talking about Suboxone. So Suboxone is another form of opioid substitution therapy that we use to treat patients with opioid use disorder. It's a sublingual film, which is a combination of buprenorphine and naloxone. And it comes in two common strengths, a 2 milligram buprenorphine, 0.5 milligram naloxone strength, and an 8 milligram buprenorphine, 2 milligram naloxone strength. And if it's used correctly, Suboxone equals buprenorphine. And Ferghal, I think you know where I'm going with this, but what does used correctly equals buprenorphine mean for Suboxone?
All right. So firstly, I think you need to understand the journey of both components of Suboxone from sublingual administration. So when naloxone is administered sublingually, it is not absorbed. It then gets swallowed and then is absorbed in the gastrointestinal tract and then heads to the liver in the portal circulation. And it is there in the liver that it is metabolized. And so there theoretically is no naloxone that ends up in the systemic circulation. So the theoretical bioavailability of naloxone is 0. Now compare that with the buprenorphine. So buprenorphine is absorbed sublingually and enters directly the systemic circulation from the venous circulation in the mouth, and then goes straight to the heart and therefore the rest of the systemic circulation. If Suboxone, if buprenorphine is administered, if buprenorphine is swallowed, it then gets absorbed in the gastrointestinal tract and then goes to the portal circulation and is metabolized. So theoretically, with the sublingual administration of both of these products, you get direct absorption of the buprenorphine sublingually into the systemic circulation. You swallow the naloxone, and then it gets completely metabolized by the liver. And so that's why you're able to deliver naloxone in combination with buprenorphine, but actually only buprenorphine gets to the systemic circulation. Now that's all well and dandy, but there's a couple of caveats to that. So firstly, what happens if you've got severe liver disease? Then you get something called naloxone escape. And so, the liver doesn't work as well. And so you end up getting naloxone being swallowed, being absorbed into the portal circulation, and then escaping the liver metabolism and entering into the systemic circulation, where it can indeed induce a precipitated withdrawal. The next question then becomes, well, what's the point of having naloxone in with buprenorphine? And so, Thileepan, would you be able to explain that one? Why do we even bother having naloxone with buprenorphine in a sublingual film?
So the purpose of naloxone in the Suboxone is as a safety mechanism and as an aid against diversion. And by that, I mean to ensure that the Suboxone is taken as it's intended to be. So as you mentioned, Ferghal, when used sublingually, Suboxone equals buprenorphine. However, when it is not taken sublingually, i.e. injected, that's when the naloxone becomes effective and then will either trigger a precipitated withdrawal or basically block the mu receptor. So it is a mechanism to ensure that the medication is taken as it's intended to be taken. So Ferghal, Suboxone's been around for a lot longer than the long-acting injectable buprenorphine that we talked about in many of the previous episodes of Cracking Addiction. How does Suboxone compare to Buvidal and Sublocade in terms of its pharmacokinetics and in terms of getting to peak plasma levels and maintaining a baseline level of buprenorphine in the system?
So it's really important to understand that buprenorphine acts quickly compared to the long-acting injectable buprenorphine products. So from sublingual absorption, buprenorphine's time to peak effect is about an hour. It can be, 1 to 4 hours. And compare that with Buvidal weekly, which has a time to peak effect of 24 hours, Sublocade, which is a time to peak effect of 24 hours, and Buvidal monthly, which has a time to peak effect of 6 hours. Now, the question then is, well, why, if sublingual absorption of buprenorphine is very rapid, why does it take up to 4 hours to have a peak effect? And the answer is, yes, it might access the systemic circulation within minutes. But to actually exert its effect, it's actually got to cross the blood-brain barrier. So that's the time delay. So we've got the effect of the absorption plus the time to enter into the blood, to cross the blood-brain barrier to then have its full effect. So it acts much more quickly. But the corollary of that is that it also lasts much less. So, you expect Suboxone to last about 24 hours. And it's got a typical peak and then a trough. And we know that the peak for dosing of 24 to 32 milligrams, we know that the peak can actually hit maybe 9, 10 nanograms per mil. But we also know that the trough can actually dip to less than 1 nanogram per mil in certain individuals. So it gives you a pattern of very high peaks and very low troughs, which is why throughout a 24-hour cycle, it is possible for people to experience symptoms of discomfort nigh on withdrawal. So compare that with long-acting injectable buprenorphine, where you have a much more smooth peak and trough, lasting weeks in the case of monthly Buvidal and Sublocade, and lasting multiple days in the case of weekly Buvidal.
Absolutely. And a lot of the time when we were talking about long-acting injectable buprenorphine in the previous episodes, we were talking about time to steady state. And for Buvidal weekly, we were saying after the 4th weekly injection, that's when we would estimate you'd get a steady state. And for Buvidal monthly and for Sublocade, we were saying after the 4th monthly injection would roughly be when we could expect to get into steady state. For sublingual buprenorphine or Suboxone, how long would it take us to get to steady state on average?
Well, theoretically, any drug reaches steady state after 5 half-lives. So the half-life of Suboxone varies, the half-life of buprenorphine varies anything between 20 to 73 hours. So we're talking about anything between 100 to 350 hours. And I can't do the maths. I mean, how many days is that? That's probably a week to 2 weeks. But the key thing about buprenorphine dosing within Suboxone is that we don't actually need to await steady state, because we know that we can dose very rapidly and get people very quickly titrated to high concentrations of buprenorphine within 3 or 4 days. And that's because it's a partial agonist. And because it's a partial agonist, it's got less risk of respiratory depression. And therefore, we can rapidly escalate doses in the right context without running the risks that we would expect with rapid titration of other opioid agonists, including methadone.
That's very true. Buprenorphine does have a very good safety profile and does lend itself to rapid dose titration to ensure patients get to a appropriate dose quite quickly. Now, we have talked a lot about buprenorphine in previous episodes, but I think it's worthwhile again talking about the metabolism of buprenorphine. Ferghal, would you mind refreshing for our viewers and listeners the metabolism of buprenorphine and how it's metabolized in the liver?
Yeah, so if you forget about liver metabolism and you are asked what enzyme in the liver metabolizes any drug, if you can't remember, then you say CYP3A4 and you have a 50% chance of getting it right. Half of all drugs are metabolized by CYP3A4, and it just so happens that buprenorphine is metabolized by CYP3A4. And so buprenorphine is metabolized to norbuprenorphine, which doesn't have any analgesic effect, but it does contribute to the risks of side effects. It's also then processed by glucuronidation. So we have buprenorphine 3-glucuronide, and we have norbuprenorphine, 3-glucuronide. And these glucuronides are then secreted into bile and therefore are fecally excreted. And so knowing that fundamentally buprenorphine is dependent on hepatic metabolism and liver and biliary excretion allows us some comfort when we're thinking about dosing of buprenorphine in the context of renal impairment. Now, even in the context of hepatic impairment, even though this medication is metabolized by the liver, in the situation of hepatic impairment is not necessarily a contraindication. It's merely a caution, and one has to just act a little bit more slowly.
Excellent. That's great information to know how Suboxone works. Another great property, I think, of Suboxone is the duration of action. And for Suboxone, you can sometimes get an effect once we've reached steady state of up to 72 hours. So that does allow us a bit of flexibility with dosing as well. And you can do second daily or on occasion third daily dosing. Yeah. Have you had much experience with the alternate day dosing regimens with Suboxone, Ferghal?
Not very much, because it's not used that often. It's useful if you've got to give someone daily pickup and they can't get to the chemist every day. That would really be the only time I would consider it. But it's really important to understand that the top dose of buprenorphine in Suboxone is 32 milligrams. Now, when you're doing double dosing, the reason why we can do double dosing is because A, it's got a half-life, that's a long half-life, and B, it's a partial agonist. So when we double dose a partial agonist, we don't have that immediate respiratory depression. So if you imagine if you double dosed a dose of endone or double dosed a dose of OxyContin, you'd be in big trouble. But because you're double dosing buprenorphine, you're not actually expecting any worsening of respiratory depression, etc., because it's a partial agonist. So the combination of partial agonism and long half-life lend buprenorphine to the idea of double or triple dosing, subject to the fact that the maximum daily dose is 32 milligrams. So if you're double dosing someone who's normally on 10 milligrams a day, then the double dose would be 20 milligrams every second day. And the triple dose, in fact, would be 30 milligrams every third day. If you were doing someone, however, who was taking 12 milligrams a day, the double dose would be 24 milligrams, but the triple daily dose would be 32 milligrams. It would not be 3 times 12, which is 36. Why? Because we know that the maximum daily dose of buprenorphine is actually 32 milligrams. And yes, you can double or triple dose, but you still have to respect that daily maximum limit of 32 milligrams.
And I guess it's really good to know how buprenorphine works, how it has that ceiling effect. But also, as you mentioned, buprenorphine is a partial agonist at the mu opioid receptor and an antagonist at the kappa opioid receptor. I know you've got quite a few acronyms about mu effects and kappa effects, but could you expand on how buprenorphine acts on the mu and kappa receptors and what physiological effects we get when buprenorphine works on these receptors?
So if we go to mu first, so a useful mnemonic for mu agonism is SPEAR. So S for sedation, P, and that would include respiratory depression, P for pinpoint pupils, physiological dependence, E for emesis, nausea, vomiting, A for analgesic effect, and R for retention of urine and retention of feces, i.e. constipation. But there are other longer-term consequences of mu agonism, which include endocrine dysfunction, so hypothalamic pituitary gonadal axis dysfunction, leading to osteoporosis, reduced muscle mass, infertility, reduced testicular function. And also we have this concept of opioid-induced hyperalgesia, whereby actually escalating doses of full agonist opioids increase or contribute to a worsening of pain. Now, the effects of buprenorphine on the mu receptor and on these side effects that I've just spoken about are less because it's only a partial agonist. Now, buprenorphine has its own set of side effects. So it can cause a wired feeling. It can be quite activating in some patients. It can give people a clear head, which, depending on the context, can either be a good thing or a bad thing. So, for instance, if you're a brain surgeon and you happen to develop an opioid use disorder, going on to buprenorphine would be a good thing because it allows you mental clarity. If you're suffering from a lot of trauma, for instance, and you're dependent on anxiolytics to get through the day, well, buprenorphine might not be the right choice for you because of that mental clarity. Buprenorphine also causes sweating, like all opioids have the ability to cause sweating. Sweating, it can cause headache, it can cause insomnia, it can cause nausea, and it can cause constipation. So those are the mu effects. Now, if we move to the kappa effects, we know that kappa agonism causes analgesic effect, it can cause a diuretic effect, and it can cause dysphoria. So, actually, opioid use disorder, by virtue of its kappa agonism, can actually cause dysphoria as well as the euphoria associated with mu. But buprenorphine, because it is a kappa antagonist, can release people from that dysphoria. Now, I'm not suggesting that, you treat depressed patients with buprenorphine, but we do know that if you start someone on buprenorphine and they've got depression, there is the potential for some kind of amelioration of symptoms.
That's a great summary of the mu and kappa effects, Ferghal. And I guess some of the other opioid side effects that we should also mention are potentially the cardiovascular effects, such as the impairment of some baroreceptor reflexes, which can cause postural hypertension. You've already touched on the endocrine effects previously, talking about testicular atrophy, infertility, and osteoporosis that can occur, and also potential risks of drug-induced hepatitis, sphincter of Oddi spasm, and xerostomia, and effects on teeth and dental hygiene as well.
Yeah, that's a really interesting point that a lot of people will say, oh, I don't want to go on methadone, for instance, because it rots your teeth. Well, it used to be that the methadone was formulated with sugar, and so it really did rot your teeth. But then methadone is now formulated with with water. But it still rots your teeth sometimes, and the answer is that it's because all opioids, and that includes buprenorphine, all opioids reduce saliva production. Now, buprenorphine less so, but still it does. And so this xerostomia predisposes people to poor dentition. Now, having poor dentition is not a reason to avoid opioid substitution therapy if it's decided that it's the appropriate way to go. Really, it's just an indication for the need for dental care. So I don't believe that bad teeth is a reason not to go on opioid substitution therapy.
Absolutely. And I guess in the episode of Cracking Addiction today, we've covered a lot on Suboxone. And Suboxone is such a big topic that we will have to break this up into another episode as well. But in the episode today, we've talked about the components of Suboxone, the pharmacokinetics of Suboxone, and the effects of buprenorphine on the kappa and mu receptors, and gone into quite some detail about the excretion and metabolism of Suboxone. So we've packed a lot of information into one episode, and please join us on the next episode of Cracking Addiction, where we continue our breakdown of Suboxone, because there's a lot to cover. So thanks for your company on the episode today, and bye for now.